This will be part 4 of the Neurolocalization lecture series where we will cover the 12 named cranial nerves. There are a number of different mnemonics that are out there to help you remember the names of the cranial nerves, but we will go through them individually for this lecture. The majority of cranial nerves are going to arise from the brainstem, with cranial nerves 3 and 4 stemming from the midbrain, cranial nerve 5 coming from the pons, and then cranial nerves 6 through 12 coming from the medulla. Cranial nerves 1 and 2 are going to be extensions from the forebrain. This concept is important to understand because when there are cranial nerve deficits, it can be quite helpful with localization. Starting with cranial nerve 1, this is the olfactory nerve and is purely sensory. There are approximately 7 paired olfactory nerves that traverse through the piriform plate, and once they reach the brain, form the optic tract as shown on the right image. It is stated that dogs can smell 100,000 times better than people, and there have even been studies assessing this, such as with using dogs to screen for cancer in people. Some studies find dogs to be 98% accurate in the diagnosis of certain cancers just by sniffing the breath or urine of a patient that is being screened for cancer. So, the ability to smell is hugely important in a dog's life, but it is challenging to assess. If an animal is actively sniffing, that means they likely receive a scent, as an animal probably is not going to sniff just for the fun of it, especially in an unfamiliar environment. However, just because an animal does not sniff does not mean the olfactory nerve is not working, and we are not going to be able to tell if both sides are working or just one side. Sometimes we will hide food under cups to see if the animal is able to find the treat, but oftentimes, we are left relying on the owner's history because a nervous animal might not try to find hidden food. It is also important to note that you should avoid irritating substances like alcohol, as this would be testing cranial nerve 5 and not the olfactory nerve. For anyone that watches my examinations, you might see me hold a cotton ball up to the nose. This is not assessing cranial nerve 1, but rather assessing airflow, because masses within the nasal cavity or sinuses can interfere with airflow, which can interfere with their ability to smell. The optic nerve is cranial nerve 2. By definition, nerves are myelinated by Schwann cells. However, the optic nerve is myelinated by oligodendrocytes. This means the optic nerve is not actually a nerve, but rather an extension of the brain itself. However, for the sake of teaching and for clinical practice, it is very reasonable to continue with the dogma of calling it a nerve. In people, visual information is responsible for almost half of the sensory input received from the external environment. In animals, it is probably not nearly as important, but we still spend a lot of time evaluating cranial nerve 2. Of course, cranial nerve 2 is responsible for vision, and the pathway for vision starts at the retina, whose axons form the optic nerves. Visual information then passes from the optic nerve through the optic chiasm, at which point the optic tract is formed. Visual information is then processed within the thalamus in a region known as the lateral geniculate nucleus. Axons projecting from the lateral geniculate nucleus form the optic radiations, which traverse to the occipital cortex. One of the easiest ways to assess vision is just to have a patient within an unfamiliar environment and watch them react to the environment. While you're taking your history and watching the animal within the exam room, notice if they bumped into walls or trip on obstacles throughout the room. This is just an example of patient with normal vision. Another way to assess vision is with the menace response. Similar to vision, the menace response starts out with the same pathway. A menacing gesture is made towards the patient, typically with our hand. That visual information will then go through the retina, optic nerve, optic chiasm, optic tract, and then to the lateral geniculate nucleus within the thalamus. From there, the optic radiations project information to the occipital cortex. That visual information is processed within the occipital cortex and then is relayed to the motor cortex within the frontal lobe. From there, the motor cortex will send information back through the thalamus and synapse on the pontine nucleus. From there, information decussates and goes to the cerebellum. From the cerebellum, it travels down to the medulla, where it synapses on the facial nucleus, and out the facial nerve for the blink to occur. It is quite amazing how quick this entire process occurs, and when the menace functions correctly, it gives us a lot of information about several parts of the brain that are functioning correctly. The problem is when the menace is absent, as a lesion anywhere along this pathway could lead to a menace deficit. We use the rest of our cranial nerve exam to help us determine the cause of the menace deficit. Another important test to assess cranial nerve 2 is the pupillary light reflex. Unlike the menace response, this is a true reflex and does not involve cortical input or the thalamus. The key central nervous system region for the pupillary light reflex is within the midbrain. This pathway starts similar to menace and vision, starting at the retina, then the optic nerve through the optic chiasm, and then the optic tract. However, these axons do not go to the lateral geniculate nucleus, but rather to the pretectal nucleus within the midbrain. This information is relayed to the parasympathetic nucleus of cranial nerve 3, also known as the Ettinger-Westphal nucleus. These axons then form the parasympathetic portion of cranial nerve 3, which innervates the pupillary constrictor muscle, causing the pupil to constrict. It is also worth noting that from the pretectal nucleus, not all the axons decussate and will synapse on the parasympathetic nucleus of cranial nerve 3 ipsilaterally. There are also going to be axons from the optic nerve that do not decussate at the optic chiasm. In a sense, the pupillary light reflex has two areas of decussation, meaning the indirect pupillary light reflex is very reliable. Going through a few examples, here we are shining a light in the right eye, and there is no constriction on either eye. For this example, we would be most concerned about a prechiasmal lesion, or something wrong with the eye or optic nerve. This animal likely has visual deficits in that eye as well. So for this example, if there is no menace in the right eye and no PLR in the right eye, we would localize the lesion as prechiasmal. For this example, we now shine the light in her right eye, and the right pupil constricts, but nothing happens in the left. Therefore, we would be most concerned about a deficit in cranial nerve 3 on the left, and looking at the light reflex in the left, I would confirm the suspicion. In this example, the animal should not have visual deficits. This is just an example of a patient where we shine the light in the right eye, and both pupils will constrict. However, when we shine it in the left eye, the pupil will start to dilate. This is known as a Marcus gun pupil and would localize to the left prechiasmal region. Please replay this section of the video if you need to see it again because it is difficult to record the pupil with a normal camera. Since we are talking about the eyes, I will briefly mention Horner syndrome, which occurs from loss of sympathetic innervation to the eye. This results in miosis, ptosis where the eyelid droops, enophthalmos, and a resulting protrusion of the third eyelid. Although the sympathetic pathway eventually is part of cranial nerve 3, it does not arise from cranial nerve 3. This often leads to confusion, but in another lecture, we will discuss the autonomic nervous system in more detail. That said, whenever we have a patient with anisocoria, we should evaluate the pupils in ambient room light and a dark room. Although, like in this patient, we do not always get an answer as to which pupil is normal, which one is abnormal, it is the best way to try and differentiate that. The dazzle reflex is something that you will come across from time to time. This is where we shine a light in the eye, and the patient will either pull away or will try and close that eye because of the bright light. This reflex is helpful in some patients when we are trying to decide if there is any dysfunction of cranial nerve 2 present. However, it is not the most reliable reflex and should be interpreted with caution. The last thing I will talk about with cranial nerve 2 is the fundic exam. As stated earlier, the optic nerve is an extension of the brain and disease of the brain is sometimes present on our fundic exam. Although not every patient will tolerate the fundic exam, it is still considered part of the complete neurologic workup, especially if we are concerned about an intracranial lesion. Next, we will discuss the nerves responsible for the extraocular muscles, which are cranial nerves 3, 4, and 6. So, we will skip cranial nerve 5 for now. Looking at the drawing on the bottom right, hopefully you can appreciate how cranial nerves 3 and 4 arrives from the midbrain and cranial nerve 6 from the medulla. Starting with the oculomotor nerve, or cranial nerve 3, it innervates the dorsal, ventral, and medial rectus, along with the ventral oblique, and as discussed earlier, the pupillary constrictor or sphincter muscle. A lesion to cranial nerve 3 will result in a ventral lateral strabismus, ventral because of gravity and lateral because of the tone coming from the lateral rectus. Additionally, mydriasis could be present if the parasympathetic portion is affected. One way to try to remember what muscles are innervated is that it almost forms the start of the letter 3. This is just an image displaying that parasympathetic of cranial nerve 3 on the right is dysfunctional as the pupil on the left constricts whereas the pupil on the right does not, despite the light being shined directly in that eye. Cranial nerve 4, also known as the trochlear nerve, only innervates the dorsal oblique. A lesion to cranial nerve 4 will result in a rotational strabismus, which is very difficult to appreciate in animals with a round pupil like the dog. However, animals like cats with a vertical pupil or ungulates like goats have a horizontal pupil, and this rotational strabismus is more easily appreciated. Lastly is cranial nerve 6, or the abducens nerve, which innervates the lateral rectus and retractor bulbi. The function of the retractor bulbi is difficult to assess unless the animal also has facial nerve dysfunction as well, and is not able to blink. However, the strabismus appreciated with cranial nerve 6 dysfunction is medial strabismus, or a cross-eyed appearance. Now we will discuss the trigeminal nerve, or cranial nerve 5. Again, 5 arises from the pons within the brainstem. This is a very large nerve, so large that if we scroll lateral on an MRI, we can see the nerve itself, as you can see here highlighted in blue. This is a transverse MRI at the level of the pons, which is highlighted in blue, and again we can still see the trigeminal nerve, which is now highlighted in green. As the name implies, the trigeminal nerve has 3 main branches: the mandibular branch, the maxillary branch, and the ophthalmic branch. The mandibular branch is responsible for innervating the muscles of mastication, including the temporalis muscles and masseter muscles, which are the main muscles for closing the jaw. Cranial nerve 5 also innervates the cranial belly of the digastricus muscle, which is important for opening the jaw, and the entire pterygoid muscle, which is important for side-to-side jaw movement. The caudal belly of the digastricus is supplied by the facial nerve, but clinically this does not seem to be important. So only the mandibular branch has motor input, where all 3 branches have sensory information. These are 2 patients with cranial nerve 5 dysfunction, specifically of the mandibular branch. The patient on the left has severe left-sided muscle atrophy on one side, and potentially medial strabismus on that side as well. The patient on the right has a dropped jaw from bilateral trigeminal nerve dysfunction. The patient on the left likely has a trigeminal nerve sheath tumor, although a neuritis is possible. The patient on the right has idiopathic trigeminal neuropathy causing temporary dysfunction of the jaw. For the sensory component of the trigeminal nerve, the ophthalmic branch is responsible for the medial canthus, the caudal and medial portion of the nasal cavity, and the cornea. The maxillary branch is responsible for the lateral canthus, the lateral portion of the nose, and the maxilla. And the mandibular branch is responsible for sensation to the mandible. The next nerve on the list is cranial nerve 7, or the facial nerve. As stated previously, this nerve arises from the medulla. The facial nerve has a lot of functions, but from a clinical standpoint, know that the facial nerve is responsible for motor to the muscles of facial expression, sensory to the inner ear pinny, and is parasympathetic for the lacrimal gland. One way that we can assess cranial nerves 5 and 7 is with the palpebral reflex. The afferent or sensory portion of the palpebral reflex is cranial nerve 5, and the efferent or motor portion is cranial nerve 7. Cranial nerve 6 is also involved with the retractor bulbi, but we generally cannot appreciate this unless cranial nerve 7 is not working. The corneal reflex could also be performed, and the pathway is very similar. However, please be careful as to not cause corneal damage when performing the corneal reflex. When assessing cranial nerves, it is important to understand the difference between a response and a reflex. In this patient, we can clearly see that the menace on the right is normal. However, the menace on the left is absent. This could be the result of a cranial nerve 2 deficit or a cranial nerve 7 deficit. The next thing assessed in this video is nasal sensation. Again, on the right side, it appears completely normal. However, on the left side, the patient does not respond, which could indicate a cranial nerve 5 dysfunction. However, when we perform the palpebral reflex, we can clearly see cranial nerves 5 and 7 are working. This is actually a patient with a right forebrain lesion and hemiinattention. This patient does not know the left side of their world exists, and you can also appreciate the right head turn in the beginning of the video. I show this video as an example, so hopefully it prevents confusion later on. Other ways to assess cranial nerve 7 is looking for facial drooping, as you can see in the images on the right. Sometimes the easiest way to appreciate a facial droop is to lift the head upwards, like on the image on the top right where the left lip is lower than the right. As stated earlier, cranial nerve 7 innervates the sensation of the inner pinny, therefore lack of sensation to this region would indicate a cranial nerve 7 dysfunction. Finally, since the facial nerve is responsible for parasympathetic innervation to the lacrimal gland, dysfunction leads to neurogenic keratoconjunctivitis sicca, and sometimes this will lead to one side of the nose drying out as well. Cranial nerve 8 is also known as the vestibulocochlear nerve. It is purely sensory and has the vestibular portion responsible for balance and the cochlear portion responsible for hearing. The vestibular system is extremely important in day-to-day activity as it maintains posture and balance relative to the head, body, and limbs. It detects acceleration and deceleration and coordinates eye movement. So if a patient has vestibular signs, then there will be one or more of the following: an abnormal posture with a head tilt, vestibular ataxia to where the patient could be rolling, strabismus of the eyes, or more concerning is the pathologic nystagmus. When assessing cranial nerve 8, the observation portion of the exam is extremely important, as we assess posture looking for a head tilt and gait looking for vestibular ataxia. Something else that is performed on each patient is the doll's eye reflex, or evaluating for physiologic nystagmus. As you can see in this patient, as we move the head side to side, the eyes will quickly click in the direction the head is moving. The sensory component for the oculocephalic reflex is cranial nerve 8, and the motor or efferent component are cranial nerves 3, 4, and 6. If the oculocephalic reflex is absent, it generally indicates a vestibular dysfunction. We can also assess hearing in animals, although just like with smell, it is not the easiest thing to do, as animals can compensate very well. A crude way to evaluate hearing is to clap loudly out of the animal's field of view to see if they turn their head. This might answer the question if they can hear or not, but it does not evaluate the degree of hearing loss or if it could just be one side. To truly evaluate hearing, we can perform a brainstem auditory evoked response where we measure the electrical activity of the vestibulocochlear nerve and brainstem. However, animals usually need to be sedated for us to perform this, at least as an adult. Cranial nerves 9, 10, and a portion of 11 are generally grouped together when we are discussing cranial nerve evaluation because there is a lot of overlap in their function. They all originate from the caudal portion of the medulla, the nucleus ambiguus, and innervate the oropharyngeal region, along with the esophagus. Cranial nerve 9 is the glossopharyngeal nerve, cranial nerve 10 is the vagus nerve, and cranial nerve 11 is the accessory nerve. When assessing these nerves, a gag reflex could be performed. The sensory portion is the vagus nerve, and the motor portion is both the glossopharyngeal and vagus nerves. When there is concern for dysfunction of these nerves, such as with a history of hacking while eating, a swallowing study could be performed which might give us a more objective evaluation of the nerves and different regions of innervation. Additionally, the larynx is innervated by the recurrent laryngeal nerve, which is a branch of the vagus nerve, and dysfunction of it could indicate dysfunction of the vagus nerve. The vagus nerve is also important as it is the major sympathetic supply to the thoracic and abdominal viscera, excluding the colon and bladder. Cranial nerve 11 has a cranial branch which overlaps in function with cranial nerves 9 and 10. However, the external branch of cranial nerve 11, or the spinal accessory nerve, is unique for a couple of reasons. First, as you can see here on the MRI, the nerve originates from the medulla but then traverses caudally through the vertebral canal parallel to the spinal cord, until it exits the canal to supply the sternocephalicus muscles and the trapezius muscles. It is rare to see atrophy of the trapezius muscles, like in this horse, but on rare occasion, you can. The final nerve is cranial nerve 12, or the hypoglossal nerve. This nerve is responsible for motor function to the tongue. It is rare to have just the hypoglossal nerve affected, however. If atrophy is present on one side, it is generally indicative of a cancerous mass. Other ways to assess cranial nerve 12 is by watching the movement of the tongue sometimes after performing the gag, or by watching the patient eat and drink. Slow motion can be helpful for this as well. A final note on cranial nerves is how we grade them. It is typically on a scale of 0 to 2, with 0 being absent and 2 being normal, and 1 therefore being decreased. This scale does not apply for all aspects of the cranial nerve evaluation, such as looking for pathologic nystagmus. Those are either present or not. This is the end of Lecture 3. From Vet Neurojar, keep those minds inspired, hearts light, and tails wagging.